Hello everyone. Assalamu alaikum wa rahmatullah. Today, inshallah, we will discuss together very important topic from exam point of view, and it's a recent recall as well. So we need to cover because in the last exam, there was two cases regarding this topic. So we will discuss today the intrauterine fetal death. So let's go with the scenario, and then I will discuss with you how you will counsel the patient about what happened exactly, and also how to counsel regarding the management options available for her. So in the exam, you will meet the patient, and this patient in the labor ward, she's para 1, and she's pregnant 34 weeks. Maybe the weeks of of the pregnancy will be a little bit different, but she's 30 something, and she presented with reduced fetal movement and now the intrauterine fetal death diagnosed. Another scenario, the patient already diagnosed with this intrauterine fetal death, and she started the induction. She received the misoprostol, and you have to manage her accordingly. So we will discuss how to manage generally the intrauterine fetal death, how to counsel the patient, and also the methods of induction. It's very important also to know how to counsel the patient about the different options and how to explain this to her. Even if it's not the intrauterine fetal death, we have another case scenario, induction of labor in anencephaly. So we want to know how to counsel the patient about these different methods. So at the start, your introduction from the early beginning of this station till the end, you have to show empathy with this patient and apologize to see this patient in such situation with this intrauterine fetal death or the death of the baby. So from the start till the end, you have to show empathy in every single word while you are discussing the situation with this patient. And then while you are apologizing to her, you're going to say you are pregnant, 34 weeks, and you have not intrauterine fetal death because it's here medical jargon. And unfortunately, the baby dies inside your womb, and you are here to discuss what about your management plan or the options available for you. Then start to gather more information, and the history here and the information gathering has to be short, to the point, because of the situation. It's not because of the emergency. Usually while the patient in labor, we have to keep the history or the information gathering targeted history and to the point and very short, and if we have any patient in emergency as well. But here it's not because of that, it's because of the situation. But also we need to cover and ask some questions to help us to reach the final diagnosis and why this happened to this patient. Sometimes you can find the cause in the questions, like if this patient has any problem during the pregnancy, any problem like diabetes, hypertension. So we need to ask about this. So the first question has to be open question. This is the best way, guys, to start the information gathering. Tell me more about your pregnancy. How was the pregnancy going so far? This patient presented to us with reduced fetal movement. So how many times? Was it the first time or is it recurrent? They found that 50% of the stillbirth, the patient presented first with reduced fetal movement. So we need to know if this patient presented one more time before today with reduced fetal movement or not, or this is the first time. Any problem happened during the pregnancy, like any infection. So how to ask about the infection if this patient got high temperature or fever, exposed to any treatment during the pregnancy, any problem like hypertension, preeclampsia, or diabetes. Any bleeding during the pregnancy, just to exclude if this patient placenta previa or there is any problem like placental separation, or you can here also diagnose, it will not be the final diagnosis, but with the placental separation, you can suspect the drug misuse or cocaine patient. And this is another scenario in the exam, intrauterine fetal death one time before, and the patient now, he or she's pregnant. And when you will ask her the questions, there is a hidden agenda, and you will find that this patient is a cocaine user. So it's very important to touch this point. Any discharge, any rupture of membrane, also it might be the cause of this intrauterine fetal death. Then continue our template as usual. So usually, guys, in the template, the first slide will be regarding the history of the present illness, and it will be different in each scenario. After that, continue your template, but choose the important questions related to this topic or this condition, like the smoking. The smoking itself can cause miscarriage, can cause intrauterine growth retardation, and intrauterine fetal death. Alcohol intake, if the patient is dependent on alcohol. And for sure, the very important point here, the recreational drugs. The BMI of the patient, just to assess the risk for VTE. So it will be like one of the patient safety points, because maybe this patient postpartum, we need to give her low molecular weight heparin. The obstetric history, it's important to know if this patient was pregnant before, and what about the outcome of this pregnancy, what about the mood of the delivery and the recovery after that. The blood group of the patient, very, very important, and it's a patient safety point here, guys. In any patient in antenatal care or maternal medicine module or management of labor and delivery, blood group very important, just to recognize if we have any patient with negative blood, like A negative, B negative, anything. Why? To highlight for her that anti-D will be given after the delivery, and also assess the fetal hemorrhage to know if we need to give her extra amount of the anti-D. And my advice here for you guys, because most of you will go for May exam, please, once you will detect the Rh negative patient, please immediately counsel her here. Why? Because in the management plan, you will forget. You know, like the smoking, once the patient will say, I'm a smoker, so you will counsel her regarding the smoking cessation program clinic referral. And if the patient wishes to do that, it's the same here. For the Rh negative ladies, please counsel her immediately. Like we have what we named anti-D. Have you heard about that before? No, doctor. So what happened that during the pregnancy, if you have negative blood and your baby is positive, so we need to screen the partner first to know if the partner is positive. So maybe this baby will be positive blood. Sorry, my dear. 1 second. So for the anti-D, guys, how to counsel the patient regarding that. I will come to this point again. So you will explain to the patient that if the baby is different in the blood group, if the mother is negative and the baby is positive, so at that time there is a risk that some of the baby's blood will escape into the mother's blood, and the mother will start to form antibodies against this baby's blood. This baby will not be affected if this is the first baby, and all the effects will be in the upcoming pregnancies. So at that time, the mother will be sensitized and the baby will be affected. So what we can do at that time, we will offer you injection, and this injection will be given during the pregnancy between 28 to 32 weeks. This anti-D will mop all the blood cells escaped from the baby. Very simple. And again, we will offer you this anti-D immediately after the delivery. In the intrauterine fetal death, if the mother is Rh negative and it's written clearly in the guideline of the late intrauterine fetal death, we have to counsel the patient about anti-D, and we need to give her immediately after delivery 500 international units, and then offer her the test to measure the fetal-maternal hemorrhage, and give extra 125 international unit per 1 ml of the fetal blood. For example, if you can find fetal-maternal hemorrhage 4 ml, so these 4 ml will be covered by the 500, no extra doses needed. If you find 6 ml, so 4 already covered by the 500, and please give the patient extra for the 2 ml, give her 250 international units. Okay? This is regarding the anti-D. So please take care in the exam, because nowadays we can find cases in the exam with Rh negative, because it's normal in our life to, while you are in your clinic, you will face these patients. So it's very important to know how to counsel them. Drug allergy, it's the safety point of all the modules. It's not only in one module. Every single module Drug allergy, very important. Any concerns regarding blood transfusion, very important also in management of labor and delivery. And why? Because this patient may bleed. We cannot guarantee anything, right? So we need to ask her if she has any reservation for blood transfusion to exclude the Jehovah's Witness. Cervical screening, it's not important here, guys, so we will remove this question here. So it's not wise while the patient has intrauterine fetal death to ask her, what about your cervical screening? Okay, so it will be like something against you in the exam. They will not take marks from you, but it's not important question to ask the patient while she has intrauterine fetal death. So coming to your question, so for the video meeting, I have to arrange that before the meeting. So if you wish, guys, to have the video meeting after that, just drop a message so I can make arrangement for that. Okay. After that, continue your template as usual. The medical, surgical, family, mental, and social. For the medical, ask the important questions like we asked in the history of the present illness about diabetes, hypertension. So here ask about any medical problem of concern, any medications you are on, like regular medications, I mean, any surgeries before, any family history of concern, especially the clot formation. Mental history is very important and crucial here because for sure this patient is affected. She will need counselor and support, even her partner as well. And this can be done in the hospital and also can be done by the GP and the support group. Social, what about support at home? And here exclude domestic violence and why. Any patient with reduced fetal movements or frequent visits to the emergency department or bruises all over the body, like in the patient with thrombocytopenia, please don't forget to exclude the domestic violence. And why? Because sometimes this will be the cause of this reduced fetal movement. The patient, she wants to be sure that my baby is okay after, for example, her partner hit her or anything like that. So she will come to the emergency department. She will not say that I have a domestic violence. She's going to say, I cannot feel the baby's movement. Okay. And for sure, the bruises, or if the patient presents to you with like falling on the stairs or anything like that, please exclude the domestic violence. And then say, thank you for sharing this information with me. It will like to show your appreciation that the patient, she's sharing with you her history. This is number one, and it will be like a pause just to take a breath and continue your counseling here. Okay, guys, so don't forget to say thank you for sharing this information with me. Do you want to add anything? No, doctor, thank you. Then continue. Next step, it has to be the examination. If you have the examination with you, so just say, I do have your examination here. So don't forget to have a look on the case notes. If you have the examination, don't say, I would like to offer you examination in presence of chaperone after your permission. And here's the examination. We have the ultrasound report. Maybe you will find extra examination results or notes in the exam, because usually it will not be like one slide like here. It will be like 2-3 papers in the exam. So just tell the patient that I do have your examination here with me. However, at some point of time, I may need to offer you examination again in presence of chaperone after your permission. And why, guys? This sentence very important, just to show that you are not undermining your colleague. Okay, for example, you have the midwife examination. It's not necessary in this scenario. In any other scenario, don't offer the examination. Just say, I have the examination, but I may need to offer you examination again to check if we have progression in your condition, to check something, anything you can tell the patient about. Okay, if you don't have the examination, so yes, offer the examination in presence of chaperone after your permission. If you want to say, I need to check your blood pressure, pulse, if you have time to do that, yes, or just keep it examination only. Okay, coming to the management plan. Here, my advice, and this is in all stations, sometimes you will not be able to remember. Is there communication with the colleagues outside in the case notes, outside the cubicle or not? So here, no NDT. It's not the multidisciplinary team by the word of multidisciplinary or the meaning of multidisciplinary team. But you can tell the patient that your management will be with a group of expert team. Okay, this is a team, will manage the patient. So if we have communication with the colleagues outside the cubicle, you will get the 2 marks for communication with the colleagues, because you enumerate all the members, all the team you will involve in her management. Like who in this scenario, like the consultant, the nurse, the midwife, the counselor, sleeping doctor if needed, because we may need to give this patient, even with the induction, we may need to give her epidural, correct? Injection in the back. We may need to shifting her to cesarean section at any time. If there is any problem with the maternal well-being, here we will not see, like if we have fetal affection of the fetal well-being, because already the baby is dead now. But if we have any concerns regarding the mother, we may need to turn this or to shift the patient to theater immediately for a cesarean section. Okay, so either to give her the epidural with the induction, or if we need the cesarean section, or if the patient choose the cesarean section from start. Some of the patients will say, no, this will be a stressful condition for me. No, please, I want a cesarean section. Okay, or patient with previous cesarean section and she refused the trial. Okay, she refused the trial to have a VBAC, vaginal birth after cesarean section. So involve the sleeping doctor. Offer the patient all the routine investigation for the labor itself, and we will discuss later what about the specific investigations for the intrauterine fetal death. Explanation of the condition. So this patient in the exam, she knows that the baby is dead now, or the baby died inside her womb. So how to counsel her regarding what about the causes for that, or to say sorry about this condition or this issue. So if we will tell the mother that the baby died before birth, this is actually devastating and extremely distressing condition. And for the patient and the family, it means the patient, the partner, even any other family member, they will be given the support for that. The cause can be known in just 50%. So 1 every 2 women, we will know the cause of this intrauterine fetal death. And what about the risk to have the baby dying before the birth? It's around 1 every 200 pregnancies. So you can highlight these numbers to the patient if you can remember in the exam. If you cannot remember numbers, guys, don't tell any number, okay? The most common reason for intrauterine fetal death, that the baby is not being growing well. So problem with the growth. Other causes can be the infection, abnormal development of the baby, like chromosomal abnormalities or any congenital anomaly, diabetes, early separation of the placenta, either placental abruption or like if we have any problem with the separation with the placenta, like having a blood clot, and this blood clot also can lead to not complete separation of the placenta, and it will affect for sure the blood going to the baby. Preeclampsia, high blood pressure, and protein in urine. So these are the causes you can highlight to the patient. And why you will highlight this? So when you will explain to the patient what about the test you will offer, at that time it will be clear why I will offer you this, for example, vaginal swab, if I need to offer you blood culture, why I need to do that. Okay, postmortem examination, why it's important, examination of the placenta, why it's important. So for each reason, we will offer the patient some blood test or some investigations. Usually the confirmation of the intrauterine fetal death will be done by ultrasound, and it's written clearly, guys, in the guideline that don't depend on the auscultation or just the CTG to diagnose intrauterine fetal death. So ultrasound, and it's better to be done by 2 experienced members, so or healthcare providers. So it's not only one to diagnose intrauterine fetal death. And if the patient can feel the passive movement of the baby after confirmation by 2 doctors or 2 technicians, at the time, please repeat this ultrasound. It's written like that in the guideline. And the patient can feel movements, yes. Sometimes, and you can also highlight this to the patient after confirmation of the baby's death, you can feel the shifting movements of the baby within the fluid in your womb. And actually, this will be very distressing. Imagine that you said your baby now is the baby died inside your womb, and the patient will say, I feel my baby's movement. So you can explain to the patient why she can feel this movement. It's just shifting movements of the baby inside the fluid, inside your womb. And if the patient feel the passive movements, please repeat the ultrasound again. Okay? If the patient wished to repeat the scan, to have another scan, yes, she can do that. So we will respect the patient in everything. I want to repeat the scan. Okay, we will repeat. I feel the baby's movement. Okay, we will repeat. Explain to her this is passive movement, but repeat the scan for her. What about the choices of birth? So the patient can choose between either the vaginal delivery or the cesarean section. Explain to her the pros and cons of each one. So sometimes the patient will think that vaginal birth is distressing, and yes, it is with the intrauterine fetal death. But please just remind the patient to think about fewer risks she will have. She will go home quickly. The recovery will be quicker and more straightforward. The future pregnancies less likely to have complication, and also in the future pregnancies, the risk to have another cesarean section will be less. So vaginal birth is usually recommended. However, you have to tell the patient that we will respect your wishes. Whatever you will decide, we are all here to support you. Okay? So usually the vaginal birth will be recommended. For the vaginal birth, we do have two options for that. Okay? Either to give or to leave the patient for natural birth, don't give her anything, or to offer her induction. This slide, guys, showing if we have a patient with one previous cesarean section, even with one previous section, we can offer a trial of VBAC. Okay? So don't forget even to tell the patient, even if you have one cesarean section before, still the vaginal birth is an option. So the two options for the vaginal birth, it will be letting nature take its course. So natural birth, we will not give the patient anything. You can choose either to wait at home for labor, to start naturally, and then to come to the hospital. And usually, most of the patients will, the delivery or the labor will start within 48 hours. Sometimes the patient will go into labor naturally. This will be like, will take longer time, but by the end, it will be within the 3 weeks. Okay? At that time, please, guys, don't forget to tell the patient that leaving the patient, or we will letting nature to take its course. At that time, there will be changes in the appearance of the baby, because it will be also a distressing thing for the mother. We need to ask the patient to come twice a week to the hospital, just to run more investigations for her, to be sure that there is no complication happen, like infection, DIC, because this is one of the serious complication and life-threatening conditions can happen if we leave the patient with intrauterine fetal death for natural birth. Okay, you must contact the hospital if you have pain, bleeding, smelly vaginal discharge, or feeling unwell. Red flag signs you will give to the patient if she will not take any medications, like she will not go with the induction. And again, after delivery of the baby, you will give her the same red flag signs. Very important, guys. Don't send any patient home without red flag signs. In many stations, like, for example, ectopic pregnancy, receiving methotrexate, patient with VIN, and she's waiting for the surgery or multidisciplinary team meeting result. So don't send any patient to home without red flag signs. Patient postpartum, any patient after the delivery, please give her the same red flag signs: pain, bleeding, smelly vaginal discharge, feeling unwell, loss of consciousness, feeling dizzy. Okay? And in some patients, we will advise her not to wait, like patient with infection, for sure, patient with pre-eclampsia. So this is letting the nature taking its course. The second option in the vaginal birth, so at the start, the two options, vaginal birth, cesarean section. Then coming to the vaginal birth, natural birth or induction. Coming to the induction. What is the meaning of that? It's the starting of the labor by giving you some medications. Some of the patients will choose to go home for a short while before starting the treatment. No problem for that. We do have different ways for induction, and we may give you one tablet 48 hours, 2 days before admission for the induction, which is the mifepristone. Coming to the methods of induction. And these slides, guys, you can use in any case you will offer induction. From here, from explanation of the induction, you can use in any patient for induction. The methods, number one will be the prostaglandins. Okay, what about when you will explain the methods, please mention the name and how it will act, and also what about the side effects. Don't forget, guys, in any station, you will give medication or a drug or a treatment, give the side effects. You will offer a procedure or a surgery, give the complications. It's a patient safety. You will help the patient to choose according to that. So prostaglandins, these medications will help to induce the labor by softening and shortening of the neck of the womb. So this is how the prostaglandins will work. This in turn will help to stimulate the muscles of your womb to start squeezing or tightening. Prostaglandins can be given as a tablet, pessary, and the name of the tablet will be Prostine, the pessary Propass. And the Propass can be inserted in the vagina or in the frontal passage. The Prostine or the tablet, it's usually possible to break your waters around 6 hours after taking this Prostine. Usually the patient will respond from the first tablet, from the first dose. However, in some patients, we may need to give second dose. Okay, so 1 or 2 tablets may be necessary. And we need to keep the patient overnight, to stay in the hospital overnight. What about the side effects? Failure, vaginal soreness if we use this vaginal, if we will use the Prostine like vaginal tablet. Okay, so if we will use it vaginally, so vaginal soreness can happen. The dinoprostone or the Propass, so it's a pessary. It's like the small tampon we would insert in your frontal passage, and it's a suitable option if the patient choose to go home. So when we need to offer, or maybe offer this Propass if your cervix or the neck of the womb does not show signs of change before labor. Okay, if the patient is overdue, or you are eligible for outpatient induction, so we can offer this, the dinoprostone or the Propass. So what about the shape? It's like a small tampon inserted in your frontal passage. It's slowly released medication, like it will release the medication over the 24 hours. Okay, it has some side effects, and again, the side effects will be the soreness of the vagina. How it will work? It will stimulate the muscles of your womb and the neck of the womb. So the neck of the womb will start to be more soft, short, and the muscles of the uterus will start to contract. Okay, so it will help to start the labor. Breaking your waters. So number one will be the prostaglandins, 2 forms of prostaglandins. Number 2, to have breaking your waters. And usually breaking your waters, if we have cervical dilatation, we can offer to the patient. Here, extra point, guys, in the anencephaly, because as I told you, for the induction, we have case of anencephaly. So the anencephaly, usually, there will be less response of the uterus to the medications. The rupture of membrane at that time will increase the uterine sensitivity. Okay? So in the anencephaly, the uterus is not sensitive like in normal pregnancy. So here, rupture of membrane will increase the uterine sensitivity. How to explain breaking the water? Making a small break in the membranes, these membranes covering the baby, and releasing of the fluid surrounding the baby. This will allow the baby's head to press more firmly on your cervix or the neck of the womb, and it will increase the strength of the contraction. Okay, guys? In the anencephaly, the problem that the baby is not, the head is not down. Okay? So usually the anencephaly will present with a breech. This is in most of the cases. So at that time, this mechanism, it will not work, like to have like press more firmly on the cervix. But what will happen at that time? It will increase the sensitivity of the uterus to the medications to contract. Okay? You got that point? You got the difference between the normal and the anencephaly? Okay. So if you have your first baby, it's likely to have a hormonal drip. This will be required to start the contractions. And usually it will start it soon after your waters have been broken. So the third option will be the hormonal drip. So we will give you this hormone with a fluid in arm, and also it will help the muscles of your womb to contract. Okay. Women respond differently to the syntocinon, and this will influence how the drip works on the contractions. Okay. And it will depend upon how ready your body is for the labor. So every woman will respond differently to the hormonal drip or the hormone drip. So again, just to recap, guys, you will give the patient two options from the start: vaginal delivery or cesarean section. Highlight the pros and cons of each quickly, because it's not a station of vaginal versus cesarean, but highlight the pros and cons, advantages and disadvantages. Then, if the patient chooses the vaginal birth, we do have two options: either to wait for the nature, or we will give some medications to induce the labor, to start the labor. These medications: prostaglandins, tablets or pessary. Number two, to have or to break the water. Number three, to have the hormone drip. Pain relief, please don't forget to cover this point. We need any patient with the induction, because the induction is more painful than the natural birth. So if we will wait until the labor will start on its own, it will be less painful. It's painful, still painful, but less painful than the induction. So if any patient with induction, don't forget to counsel her regarding the pain relief. We can offer her simple painkillers, to have a warm bath. Also, the patient can use the gas and air, or epidural, which is injection in the back. Okay, but highlight to the patient that she will not be mobile. She will be immobile, but she will not feel anything like the pain or the contractions or anything when the baby is delivered. So we are done with the slides of induction, guys. So today I can say that this slides can cover many stations in the exam: the induction in case of intrauterine fetal death, the induction if the patient overdue, for example, the induction in anencephaly, and it's a recall, it's a recent one as well. And it will cover the intrauterine fetal death, how to counsel the patient for induction. And if the patient start the induction, so we will start from here, how you will continue the induction and the labor, and then when the baby is delivered, how to manage. So this patient will need support. Her partner will need support. You may even offer support for extra family members. Okay? You will be able to see and hold your baby. It's very important to tell the patient like that. If you want to wait to see your baby a little bit, no problem for that. Or you can decide not to see the baby at all. So the patient has to decide either to see the baby immediately, to spend as much as she wants or needs with the baby. She can hug the baby, and she can decide, no, I will not see the baby now, just leave me for a while. Or she will decide, no, I don't want to see my baby. It will be like a heartbreaking thing for me. So it will be the patient decision at that time. The patient can spend as much time as you wish. You tell the patient like that, as you wish. And also you can name your baby. 1 second, guys, just to admit your friends here. They are waiting. Photographs, hand, footprints, locks of hair, if possible, for sure, can be taken. No problem for that. And the patient can take these samples to home. Nowadays, they are making like it's like the on the wall to have like a memory, and they will put these samples like the footprint, the handprint, one photograph of the baby, and a sample of the hair. If the patient doesn't want to do that, or not now, so we can keep this securely in the hospital records, and then the patient can take them after that. So maybe after 1 month, 2 months, according to the patient wishes. And also highlight this to the patient in the exam, because if the patient received the induction, We will not discuss more about the induction. You will just continue how you will manage and then discuss what after the delivery of the baby and the investigations. You got the point? So it will be according to the scenario, guys. Registration of the baby or the birth, yeah, we can do that if the baby more than 24 weeks of gestation. And also the religious and cultural considerations will be taken into account. The support group or local support group and SANS, they are dealing with any partners or any parents having this intrauterine fetal death. And usually the GP will advise them and they will give them more information. Some of the patients will decide to go home immediately. Some of the patients will decide to stay in the hospital. So it will be according, even here, guys, to stay in the hospital, it will be according to the patient wish. If the patient has any problem, like if the patient not feeling well, so we can keep her in the maternity unit for a little longer. So all about the patient wishes here in this topic or with the intrauterine fetal death. Breast milk, don't forget to touch this point because also it will be a distressing point for the patient to have a breast milk, to have engorgement, to have pain or discomfort in her breast. So after birth of your baby, you may experience the sensation of the breast milk. So what to do at that time, we can offer you, or you can use the ice packs to reduce this sensation, to have a good breast support, and a pain relief like using ibuprofen or paracetamol. However, one woman every 3 women, so 1 in 3, will have excessive discomfort. And at the time, we can offer you a tablet which will stop the body producing milk and relieve your symptoms in a short time. And this will be in 1 in 3 only, 1 in 3. Okay? Red flag signs. Now the patient delivered her baby, everything done for the patient. Please don't send her home without the red flag signs, like if you have bleeding, pain, smelly vaginal discharge, feeling unwell or shivery, pain, swelling of the leg, or chest pain, or shortness of breath, please come immediately to the emergency department. Or in the discharge letter, we will offer the patient a contact number. It's a 24/7 contact number. Please contact this number or come immediately to the emergency department. So don't send any patient without red flag signs. You can use the same. You can use the same, guys, for any patient postpartum when you will send home. To continue the management plan, you can highlight to the patient the test will be offered to her. So we need to offer her liver function test, kidney function, how to tell her in layman language. We'll come to the test. I put the tables from the guideline by the end of the case, but here how to counsel the patient in layman language. So we want to see, or we need to see, how's your liver work, how's your kidneys work, and also we will offer you some blood tests to see if we have high blood sugar level, and also to check your thyroid function. The thyroid is a gland here in front of your neck. So when you will tell thyroid, not all the patients will know thyroid. So it's a gland in front of your neck here. So we will offer you some tests, some blood tests to see the function of this gland. And also we will have some blood tests to see if you have problem with your blood, which makes your blood more likely to clot. And if it's positive, we will repeat again after 6 weeks. Okay? We will offer you some swabs from your vagina or frontal passage, from the neck of the womb, from the afterbirth. Sometimes you can use the vagina, like layman language, but it's better to say frontal passage, neck of the womb, and the afterbirth to check the baby and also to see if we have any source of infection. The baby's chromosomes, it's like a tiny structures inside our cells. And some of the cases of this intrauterine fetal death or the death of the baby before birth can happen due to abnormality in these chromosomes. So we need to check, but we need your consent before that. So we can take a blood sample, skin, muscle samples from the baby to see if we have any chromosomal abnormalities. And at that time, if it's positive, guys, please offer the parents a test if it's positive. So not from the start to offer the parents test for any chromosomal abnormalities, Okay? No, if the baby's chromosomal test is positive for any problem, at that time we will offer the parents another test. Postmortem examination, very important also to discuss. And please, one of the safety points, don't forget the consent. It has to be a written consent because we will take samples from the baby. Okay, detailed examination of the afterbirth also will be offered. So examination of the baby and placenta. Follow up, when we will see this patient, usually it will be after 12 weeks because all the blood tests and the swabs and the post-mortem examination can take up to 12 weeks. So set another appointment within these 12 weeks to see the patient again. What about the future pregnancy? Any case, guys, any problem like this with the pregnancy, with the current pregnancy, please don't forget to touch the future pregnancy. For example, another example, guys, patient with perineal tear now, don't forget to touch the future pregnancy. Patient with shoulder dystocia, touch the future pregnancy. So any complication in this pregnancy, don't forget the future pregnancy. So this patient has to present early to us for booking. The follow-up will be under the consultant care, to be seen early, and to have extra antenatal visits, more frequent visits in the upcoming pregnancies. Now we are done regarding the intrauterine fetal death, how to counsel the patient in a simulated patient task. I involved here extra slides from the guideline for the test offered. In case of, we will face this like structured discussion, not simulated patient task. Because in the simulated patient task, the test, you will summarize the test for the patient, like this slide. Look here, guys. To be very simple for the patient to understand. Some blood tests, some swabs, examination of the afterbirth of the baby, discuss with her more about the postmortem examination. But if you will face a structured discussion, we need to explain more about the test and also for your knowledge, how to offer or what to offer for any patient with late intrauterine fetal death. So we need to offer this patient the normal, not normal, the routine blood test like full blood count, liver function, kidney function, okay? CRP, bile acids, okay? So it's like the routine one, maternal standard hematology. Okay, guys? What else? The coagulation profile for the patient to diagnose DIC. To offer her test for the fetal-maternal hemorrhage if the patient is Rh negative or the blood group unknown, and then you offered her and you found Rh negative. Maybe she wasn't discovered in the previous pregnancy, our patient para-1, and she's a sensitized lady. So at that time, this can be the cause. There is like a fetal hemorrhage or fetal anemia happened inside the uterus. So at that time, this will be the cause. Or even if she was discovered before, so we need to offer her the NTD after the delivery. What else to offer? Some bacteriology tests, like to have blood culture, midstream urine, vaginal swabs, cervical swabs, if you suspect any infection, okay, like listeria or chlamydia. So we need to offer these blood tests for the patients. Some maternal serology for viral screen, syphilis, and some tropical infections, if you suspect for the tropical infections. For the syphilis, if it's not done at the booking visit. So viral screen, syphilis to detect any occult maternal fetal infection. Maternal random blood glucose level to see if this mother is diabetic. Hemoglobin A1C to diagnose, here not to diagnose gestational diabetes, it's just to see if this mother blood glucose level was uncontrolled over the last 3 months. It means that her blood sugar level was high during the pregnancy. Because maybe the random now is high because of the situation or anything else. Okay, you got the point? So here, just to reveal the blood sugar level control over the last 3 months. Maternal thyroid function, occult maternal thyroid disease. The hypothyroidism also, it's a cause. okay, or hyperthyroidism. So we need to offer this lady a thyroid function test. What else, guys? Maternal thrombophilia screen to see if we have any thrombophilia in the patient, especially if this patient, we can find like a placental blood clot or a positive family history. At that time, offer her thrombophilia screen. Anti-red cell antibody, very important because it may induce the hemolytic anemia. It's like the anti-D. When I told you maybe this mother was not discovered in the previous pregnancy. So you know the hemolytic disease of the fetus and the neonate. It's one of the causes here. Anti-red cell antibody. Okay. Maternal anti-Ro and anti-La antibodies. Anti-Ro and anti-La, it's usually linked to the autoimmune disease, and usually it's causing fetal heart block. This is the cause of the fetal death. So anti-Ro, anti-La, it's very important in the autoimmune disease, and it causes fetal heart block. Maternal alloimmune antiplatelet antibodies to check if we have any thrombocytopenia. It's very important also, and thrombocytopenia, guys, very important topic to cover, okay, from exam point of view. Paternal bloods for karyotyping, and when to offer paternal blood if we have problem with the baby. So indicated if fetal unbalanced translocation found with the postmortem examination of the baby and placenta. So we will not offer parenteral unless we have problem with the chromosomal investigation or the chromosomes of the baby. Maternal urine for cocaine, very important. Please, guys, take care of the cocaine in the exam with any case with intrauterine fetal death, any case with placental abruption or bleeding. So to detect the occult drug use. Sometimes even if you suspect, and the patient, she said, no, I'm not using any drugs, but you suspect in this patient, like, no, not for sure, but you suspect this like highly suspicious case, at that time, offer her urine cocaine metabolite test. Fetal and placental microbiology, the fetal blood, fetal swabs, and placental swabs for any fetal infection. And we can take parts of the fetal skin or muscles for chromosomal abnormalities as well. Fetal placental tissue for karyotyping, so deep fetal skin, fetal cartilage, placenta, to diagnose any chromosomal abnormality. Postmortem examination, external, the features of the baby. Okay, maybe you will see the baby and say it's hydrops baby, hydrops fetalis. So you got the diagnosis, and now search for the cause. Is it immune or non-immune? Microscopy, you can offer the baby X-ray and placenta, parts of the placenta to be examined under microscope, and also the core. So these are the investigations, a long list, guys, just to go through the investigations, have a look at, but if you will have the patient in front of you, so it's simulated patient task, use the first slide, very simple in layman language, okay? Patient safety points here. We have some points, it's like with all the cases, like to have good explanation. If the patient, she doesn't know the condition, for sure to do the breaking bad news, explain the intrauterine fetal death and what about the causes, explain the options she will have. Don't forget the blood group and the drug allergy. It's the, and here the RH as well, it's for any patient in labor or pregnant. To offer her the appropriate management plan, guys, it's one of the patient safety. So take care of that. VTE risk assessment by asking her about her BMI and questions from the history and the family history. Okay, so this is a VTE risk assessment. And touch this point that we will assess you regarding the clot formation in leg or lung. And if we can see any risk, we will offer you a blood thinners and elastic stocking. So don't forget to touch this point. Any patient pregnant, any patient in labor, any patient postpartum. Don't forget to give the pros and cons of each option, like vaginal birth versus cesarean, but please to be quickly, because we have the methods of induction. When you will touch the point of waiting for the nature, So don't forget to give the complications, like to have a serious complications like DIC. Okay. Documentation of everything. So by the end, you will tell the patient that I will give you the written information. I will show you this slide, next one. I will notify my consultant about you, and he will be here in a while, and I will document everything. And if the patient, you discuss with her the postmortem examination now, please don't forget to touch the point of the consent. Even if she will not sign now, she can sign after the delivery, because also she's in a distressing condition now. But just touch the point of this postmortem examination will need consent from you, a written consent. Okay, so notify the consultant, admit the patient in the labor ward. So the patient with you, give her the information leaflets, notify the consultant, and document the discussion and document the decision of the patient. Okay, so this is how you will finish this station, guys. Any questions? Any questions? Yes, go ahead, Dr. Osini.
All right, thank you very much for the elaborate presentation. So my question
Thank you.
is, so for patients with IUFD, I know that amniotomy, you tend to delay amniotomy as much as possible to reduce risk of infection. But it was one of the methods that you discussed for induction in this case. So how do we go about it?
So, sorry, come again with the question, Dr. Osini. For the
I
induction
said
in case of infection?
yeah, for patients with IUFD, so we
Mm-hmm.
tend to delay amniotomy to the time of delivery as much as possible because of risk of chorionitis and all. So,
Yeah.
but now amniotomy was one of the options that you gave for induction of labor. So I'm now
Mm-hmm.
saying, how do we balance this when you are explaining to the patient?
Yeah, I got your question. So for the rupture membrane, now you have this patient and you will start to give her prostaglandin first, okay? And there is the response, but it's not the sufficient and enough response or the contractions to facilitate the labor. So at that time, if this patient, she's dilated like 3 centimeter, 4 centimeter, you can offer her rupture of membrane, because now the the um, the labor already started. You will not use this an option from the start, from the early beginning of the induction. So the risk of infection will be less because already the cervical dilatation started. You got my point? So it will not like from the early beginning of the induction.
Yes, I get your point. Thank you.
You're welcome. And for sure, if you have any risk, if you suspect infection in this patient, so you can offer her also coverage of antibiotic if you have any infection, like with the swabs, if you have, but the swabs will take time to come back to you. So if you have any fever, for example, the patient with fever, so now, yes, you suspect that this patient has infection. So you will delay the rupture membrane as much as you can. Okay, but for any patient, usually we will offer her the rupture of membrane after the cervical dilatation. So now the labor already started. We have here another question. You're welcome, doctor. Thank you so much. Yeah, how to do the breaking bad news. So usually the breaking bad news, guys, we need to give first signpost. It's very important. Give first signpost and then second signpost. So for example, if this patient presents to you with reduced fetal movement and you diagnose the intrauterine fetal death with the ultrasound, how to do that? So just say, I can see that you are here today alone. Do you want someone to be with you? Or do you have anyone outside, like your partner or any one of your family members? No, doctor. Please go ahead. Tell me what happened. So I'm so sorry. I think I don't have a good news for you. This is the second signpost. So you are preparing the patient for this bad news, giving the first signpost and then the second one. So I'm so sorry. I think I don't have a good news for you. So now you present it to us with this reduced baby's movement, and we offered you a scan. And unfortunately, the scan showing that your baby's heart stopped working. I'm so sorry about that. Full stop. Or the ultrasound showing that your baby is dead inside your womb. And full stop, leave the patient to absorb. Take care of the breaking bad news. You will face 1 or 2 cases in the exam in the breaking bad news. So leave the patient. I know that most of you will be, I want to finish the station quickly, and you will continue to speak. No, wait for a while, leave the patient to absorb the shock. And if the patient she's starting to cry or anything like that, offer her a tissue paper if it's in front of you for sure. And then ask her, is it okay to continue the consultation now, or do you want some time? Or do you want, it will not be like arrange another appointment here because it's intrauterine fetal death, the patient in labor ward. So just to leave the patient for a while. You can ask her like this. And because we are in the exam, she's going to say, no, please, doctor, continue. What you will do now with me? And is it sure, doctor? So you can, if it's done the ultrasound once, so you can offer her the second ultrasound scan. So this is how you will do breaking bad news in any case. Okay, please don't forget to give first signpost, second signpost. Any questions? Any other questions? Okay. Okay. Thank you so much. You're welcome, Dr. Heba. Thank you so much, Dr. Heba. Okay, guys. So thank you so much for your attendance. I will be sharing the recording once it's ready. And I will, sorry, we have another question. Yeah, the postmortem, very easy, Dr. Rushna. Just to tell the patient that we will have some swabs from the baby, and the after birth, we will take part of it and it will be examined under the microscope if you want to discuss more. And we will have like a small sample of the baby's skin and the baby's muscle to be examined also under microscope. Full stop. So this is a postmortem. If you don't want to dig more, so we will examine the baby and taking swabs to see if we have any infection, and we will examine the afterbirth under microscope. Okay, this is how you will discuss the postmortem. Okay, guys. So thank you so much for your attendance. You're welcome, Dr. Rushna. I will try to arrange another meeting with very important topic also from the recent exam, just to cover it before your exam, guys. So I will try. Maybe it will not be next week because it's like I'm very busy next week. Maybe the week after, I will choose one topic very important and we can discuss also. Okay. And if you have any suggestion for that, just to say we need to discuss this, just drop the message on the group, the case discussion, or on the study group, whatever, anyone, or direct message, no problem also. Suggest for me one topic to discuss next time. Okay. Thank you so much. Assalamu alaikum wa rahmatullah.
Thank you very much.